Radial pulse is easily palpable, but the left radial pulse is decreased. It is CT. Patient is not hemodynamic. Sorry, patient is not hemodynamically unstable. Patient is hemodynamically stable, not that unstable. So traumatic signs of traumatic arterial injury where surgery is needed. Now, if there is hard signs, it is bad. Bad is bruit, absent distal pulse, active hemorrhage, or rapidly expanding hematoma, and distal limb ischemia. So hard signs are bad and require surgery, and soft sign makes you sad and it requires some imaging. So stable hematoma, associated neurologic finding, associated neurologic deficit, diminished pulse, documented hemorrhage, and hypertension. Unexplained. Okay, soft sign. Unexplained. Soft sign. Okay, clavicle fracture is the common. mm, Clavicle fracture is a common sports related injury. Common sports related injury can occur following a blow or a fall on the shoulder or outstretched arm. Vast majority are uncomplicated and carry a favorable diagnosis. However, the middle third of the clavicle third overlies the brachial plexus and subclavian artery or vein in the thoracic outlet. Therefore, clavicle fracture require careful neurovascular assessment. The presence of heart sign, uh, absent distal pulse, bruit at the site of the injury following a fracture indicate definite arterial injury required immediate surgical intervention. Following the presence of stable hematoma, as in this patient, reduced pulse, documented hemorrhage, and the documented hemorrhage at the time of injury, unexplained hypertension, or an associated neurologic deficit also suggest an arterial injury may have occurred. These soft signs require vascular imaging to confirm and localize the site of the injury. CT angiography is the diagnostic modality of choice due to high sensitivity and specificity and rapid procedure time. Okay. It is due to drugs like penicillin, serum sickness like reaction, isn't it? So look at the box and it will give everything. Okay, serum sickness due to foreign proteins in antivenom, antitoxin, and monoclonal serum sickness, foreign protein in antivenom, antitoxin, and monoclonal antibiotic, and serum sickness like reaction usually happens due to particularly cefaclor, penicillin, and TMPSMX. Immune complex high titer serum sickness and serum sickness like reaction mild or none. Complement activation extensive serum sickness like minimal or none. Serum sickness onset 5 to 14 days after exposure. Serum sickness like reaction 5 to 14 days after exposure. Serum sickness, there is fever, high fever, arthalgia, urticaria is present, and serum sickness like reaction. There is low grade fever, arthalgia is present, urticaria is present. Serum sickness usually spontaneous resolution. Serum sickness like reaction spontaneous discontinue if still receiving. Okay. Yes. Okay. This patient most likely has vertebral osteomyelitis. Patients with injection use such as anemia, immunosuppression are at highest risk. Staph aureus is the most common pathogen, but infections with gram-negative organism can also occur. Many cases of vertebral osteomyelitis are chronic, more than 6 weeks, are insidious with minimal non-specific symptoms, often initiated attributed to muscular back pain. Many patients have worsening back pain unrelieved by rest. Fever is present in less than 50% of the cases. Physical examination often shows. Okay, physical examination. Mm, Many patients worsening back pain unrelieved by rest. Fever is present less than 50% cases. Physical examination often shows few findings. Focal tenderness on gentle percussion over the spinous process of the involved vertebra L3, L4 in this patient, and can be an important clue. Paravertebral muscle spasm, paravertebral spasm, and reduced spinal range of motion may be seen. A high index suspicion should be maintained. Worsening back pain with localized spinal tenderness in a patient with injection drug use. In addition, uh, fever being an unreliable finding, leukocytosis may be elevated or normal. Elevated platelet count may be present. Mm, elevated platelet count may be present, marker of inflammation. and erythrocyte rate. ESR is often significantly elevated. MRI is the most sensitive diagnostic study. Treatment includes long-term IV antibiotics with or without surgery. Well, okay. This is myotonic dystrophy, autosomal dominant CTG. Okay. Inverted V-shaped upper lip. Okay. This patient, muscle pain. Do you need to see the explanation? Okay. This patient's muscle pain, weakness, and delayed relaxation are concerning for myotonic dystrophy. Myotonic dystrophy is an autosomal dominant disorder in which CTJ repeat in the DMPK gene is transcribed into untranslable mRNA that is toxic to the cellular function. Longer repeat expansion is generally correlates with an earlier onset more severe disease anticipation. Presentation classically involves muscle weakness, pain, atrophy, particularly in the distal hands and feet, and facial long and narrow face, sagging jaw, hollow cheeks, uh, stuff. uh, Foot drop may result in infrequent falls and unsteady gait. Myotonia is characteristic feature and can be elicited by percussion of the thinner eminence, which results in thumb abduction followed by delayed relaxation. Percussion myotonia, or by, do you know how it is done, this percussion myotonia? I don't know actually. Like in the stem, they have told that percussion over the thinner eminence is tapping the thinner eminence will delay relaxation. Okay. Okay. Yes. So it is not abducting. It is adduction, isn't it? Uh, Again, wait. I don't know. It should be uh, abduction, abduction, adduction, abduction. Okay. 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 I haven't got the. Okay. I don't know. Give a restart. Okay, go back from here. Like click the back space. Yes, again. Okay, no. Where is your rival? Your rival is angry. Your rival is angry with you. Okay, you are back. Okay. Percussion myotonia. Grip myotonia. Involvement of cardiac muscle can result in cardiomyopathy or arrhythmia or sudden cardiac death in patients. Sudden cardiac death in the patient's father raises suspicion for undiagnosed myotonic dystrophy. Non-muscular manifestation can include hypogonadism with decreased libido and testicular atrophy. As seen in this patient, the diagnosis based on clinical findings and family history DMPK testing is confirmatory, including physiotherapy for weakness and testosterone replacement for symptomatic hypogonadism is generally supportive. Okay, next. What is your diagnosis? Yes or not? Yes. What you will find in the X-ray? Nothing. It is there any fracture? No. Arthosynthesis can be done for septic, like you have said. If there is inflammation, signs of inflammation, signs of sepsis, then you can do arthosynthesis because it can cause septic or inflammatory arthritis, like rheumatoid arthritis can come with this sort of this. Okay, this patient with has oligoclonal bursitis presenting as localized swelling over the posterior elbow, localized swelling over the posterior elbow. The oligoclonal bursa is a fluid-filled synovial sac located between the olecranon process and the skin. It alleviates friction at the bony prominence due to its exposed location. Repetitive pressure overuse due to upper extremity exercise or other microtrauma can injure the bursa, leading to synovial joint inflammation. The rounded golf ball shaped fluid accumulation. The rounded golf ball shaped accumulation in the bursa is commonly apparent on inspection and is fluctuant or palpation. Chronic microtraumatic bursitis is inflammatory, so erythema and significant pain are usually absent because the bursa is not an intra-articular bursitis. Typically does not interfere with the range of motion usually. Treatment involves activity modification to decrease the elbow friction, ice, NSAIDs, and elbow padding. What is elbow padding? Other etiologies of oligoclonal bursitis include. Oh, stop. Okay, your things are not working. Okay, if you wish, you can see elbow padding. Other etiologies of oligoclonal bursitis include acute trauma, hemorrhagic bursitis. Okay, like cyclist and cyclist do. Okay. 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 The letter there is a problem then. It will come again. Again, you have to restart your computer, then it can be solved. Maybe. Okay. Okay, other etiologies of oligoclonal bursitis include acute trauma, hemorrhagic bursitis, infection from abrasion penetrating trauma, rheumatologic disease, gout, rheumatoid arthritis. The latter two present with redness, warmth, significant pain, and features absent in chronic microtraumatic bursitis. These features necessitate a complete blood count with differential as well as aspiration of the bursal fluid to rule out the infection. Okay, is it molding cast like clubfoot? Okay, and reassurance for metatarsal adductors. There is another term like just similar to clubfoot. Okay, this patient has a bilateral congenital clubfoot talipes equinivarus. Talipes equinivarus, a deformity caused by abnormal development of a deformity caused by abnormal development of the talus, abnormal development of talus bone. In most cases, the deformity is isolated without other structural abnormalities. The etiology is likely multifactorial, may include genetic factors, long-standing intrauterine immobility, oligohydramnias and or certain underlying chromosomal or neuromuscular disorders spina bifida. In a developing fetus with congenital clubfoot, the connective tissue, the musculature of the foot, and the distal cuff surrounding the talus bone do not fully develop. This leads to plantar flexed foot with an adducted and internally rotated forefoot. Congenital clubfoot is fixed deformity which can be seen on imaging as an affected foot in the same plane as the tibia or fibula, even with fetal movement. As in this patient, initial management of the congenital clubfoot is gentle manipulation with serial molding casts, ideally beginning in the neonatal period. Once an optimal position is achieved by casting, long-term bracing is typically required. Surgical correction is reserved for refractory cases or recurrence of the clubfoot after non-surgical treatment. If untreated, clubfoot leads to an abnormal gait with weight bearing on the lateral aspects of the foot. This patient likely has patellar dislocation which occurs after quick lateral movements of a flexed knee, and is most common in young athletes, soccer or ice hockey players, gymnasts, dancers, mm, and gymnasts, dancers, military trainees. Patients may feel the knee giving away, giving way, followed by a popping noise or severe pain. The quadriceps muscles normally exert a lateral force on the patella, especially during quadriceps contraction. Therefore, in cases of patellar dislocation, lateral displacement with associated tear in the medial patellofemoral ligament, which normally provides an opposing medial force, is common. Superior and medial dislocation are rare. Risk factor for patellar dislocation include age less than 20, joint laxity, lower extremity malalignment, patellar subluxation, excess lateral movement within the trochlea. Examination shows a flexed knee with a range of motion and a lateral displacement of the patella seen as a large immobile deformity in this patient out of the trochlea, which may be palpable as a depression or at the anterior knee. Other clinical findings include hemarthrosis and tenderness along the medial patella, reflecting tear of the medial patellofemoral ligament. X-ray may not be needed for diagnosis in clinically apparent dislocation, but are preformed after reduction to rule out additional injury. Patellar dislocation often reduces spontaneously, however, close reduction is required for patients without spontaneous resolution. Follow-up care includes splinting and rehabilitation for muscle strengthening. Anterocruciate ligament ACL tears are usually due to rapid deceleration or pivoting at the knee with the foot planted. The medial tibial spine intercondylar tubercle is the insertion of the ACL. Avulsion fracture can occur in younger patients and have similar mechanism as ACL tears. Acute hemarthrosis is common in this injury and may limit the extension of the knees, but the patella remains seated in the trachea. Okay.
Hmm? Jesus.
Okay. This young woman with constitutional symptoms. This young woman with constitutional symptom, fatigue, thrombocytopenia, probable mitral regurgitation, hollow systolic murmur, and positive ANA suggestive of SLE, now has cerebrovascular accident, sudden onset unilateral weakness, and negative CSF. Given this feature, antiphospholipid antibody syndrome in the setting of SLE likely. Antiphospholipid antibody syndrome presents with a thrombotic event, DVT or arterial thrombus, and pregnancy morbidity, fetal loss, severe preeclampsia, placental insufficiency, plus a positive serology 1 of 3 antiphospholipid antibodies, anticardiolipin, anti-beta 2 glycoprotein, and lupus anticoagulant. The biggest risk factor of APS is SLE. APS occurs in up to 40% of this patient. A minority of healthy individuals may develop transient antiphospholipid antibody. So all positive serology for APS should be reported at 12% to confirm the diagnosis. Patients with APS often require anticoagulation for life, heparin production, or warfarin, as the risk for recurrent thrombus is high. For those with concomitant SLE, hydroxychloroquine is added. Okay, okay. MS presents with neurologic symptoms, transverse myelitis causing a paraplegia, and paraparesis is much more common in than the hemiparesis. As MS is an inflammatory, symptoms tend to develop over hours or days, not suddenly. MS also would not explain this patient's hematologic abnormality, positive ANA, rapid plasma reagent, or murmur. Neurosyphilis can occasionally present with arteritis causing a cerebrovascular event. Arteritis causing a cerebrovascular event in a young patient, but it is typically accompanied by abnormal CSF cell counts, lymphocytic pleocytosis, 10 to 100 10 to 100 per millimeter cube. 10 to 100 per millimeter. Can you hear me? Okay. In patients with APS, a false positive. In patients with APS, a false positive RPR test is uncommon, is not common, is not uncommon. So what is happening now? My computer is getting problem. In patients with APS, a false positive RPR test is not uncommon as the syphilis antigen used in RPR testing contains cardiolipin. Polyarteritis nodosa can cause CVA, cerebrovascular accident in minority of the patient, but mononeuritis and polyneuropathy are more common. In addition, other findings such as arthalgia, myalgia, and cutaneous renal and gastrointestinal disease are often present. Rheumatic fever can cause chorea-like movements, Sydenham chorea, and is commonly present with carditis and migratory arteries. Okay, okay. Have you answered? Okay. I, my laptop is causing problem. That's why I'm not seeing you. Okay. I can hear you, but I can't see your screen. Okay. I don't know what is happening. Okay, no problem. So it is osteosarcoma. It is sunburn appearance. There is Codman's triangle. So do you want me to read the explanation? Okay, next then. Is it GTPS? Okay. Meralgia parasitica, there is, okay. It may be lateral aspect of the right hip. There is tenderness. Okay, look here. Meralgia parasitica has anterolateral pain, but they in here they said you in the first line that there is lateral hip pain. It make difficult for him to lie on that side while sleeping. In GTPS, greater trochanteric pain syndrome, there is something like that. When you lie on that side, it causes pain, and there is also tenderness. So looks like GTPs. Have you given up? Okay. Do you want me to read the explanation? Okay, this patient has greater trochanteric pain syndrome. I am unable to see your screen. That's why I am asking. Okay. No, no. It will actually cause lots of trouble. This patient has greater trochanteric pain syndrome. The GTPS is an overuse syndrome. The GTPS is an overuse syndrome involving the tendons of the gluteus medius and minimus, where the medius and minimus, where they run over the greater trochanter, GTPS, also termed trochanteric bursitis. Although the bursa are not the source of pain in most patients, GTPS typically presents with chronic lateral pain that is worsened, with repetitive activity. That is worsened with repetitive hip flexion, like climbing stairs, walking uphill, and getting out of the car. Lateral hip pain that is worsened with hip flexion, climbing stairs, walking uphill, and getting out of the car, or lying on the affected side. The diagnosis of the traumatic pain syndrome is based on clinical findings. Physical examination shows local tenderness over the greater trochanter during flexion, and hip range of motion is normal, although abduction may aggravate the pain. X-ray is commonly performed to rule out the concurrent hip disorder. An ultrasound may show chronic degenerative tendinosis of the affected joint. Okay. Okay. Have you answered the question? This patient with blunt chest trauma. So on that question, like in the clavicle fracture previously we found a question with clavicle fracture where there is traumatic arterial injury. Uh, have you remembered like heart signs? Okay. For that heart signs, uh, sorry, for that soft signs, we actually do imaging, and CT scan is the imaging, maybe. On on Yes, on that question, CT angiography, but that was the clavicle fracture too, isn't it? So in here there is clavicle fracture, but we are doing the CT scan of the chest. Okay, this they are talking about blunt chest trauma. Okay, that is the thing. Okay, blunt chest trauma as a community. So I'm not getting it. In like on that question, that was the clavicle fracture. This one is the clavicle fracture too. That clavicle fracture, when we are doing imaging, that one is CT angiogram, isn't it? Yes, CT angiogram of the chest. Uh, yes, they are looking for the they are looking for brachial plexus injury, isn't it? Like subclavian vessels injury on that question. Yes, if pulses is low, that's why we are doing imaging, isn't it? Okay, in here pulses are normal. Oh, okay, IV fluid is administered to improve. So this patient with blunt chest trauma, striking a brick, striking a brick has comminuted displaced right clavicular fracture. He has signs concerning for hemorrhagic shock, hypertension, tachycardia, diaphoresis, and subcutaneous bleeding, bruising, swelling in the right clavicular area and upper chest. These presentations are concerning for fracture associated injury to the subclavian vessels, which are close proximity to the clavicle and typically travel beneath its middle third. Even patients seemingly minor blunt chest trauma can have more serious intrathoracic injury and hemodynamic instability consistent with ATLS principle. Such patients undergo simultaneous resuscitation, that is IV fluid bolus, and evaluation. Clinical examination chest X-ray to look for life-threatening injury. Further management then depends on their response to resuscitation. Patients such as this one whose condition improves with resuscitation undergo further testing to visualize intrathoracic injury because displaced clavicular fracture can injure the pleura or lung pneumothorax, subclavian vessels or brachial vessels, they are the best. Uh, they are best evaluated with CT scan of the chest, typically IV contrast. Patients who remain unstable despite resuscitation requiring room thoracotomy. Okay, soft. And if more feature on the chest feature, then we will go for a CT scan of the chest. Yes. Extension, flexion actually improves, isn't it? Okay, okay, it's spondylolysis pars fracture. That is spondylolysis. Yes, true. Okay. These gymnasts persistent low back pain. These gymnasts persistent low back pain and is concerning for spondylolysis, a unilateral or bilateral defect, fatigue fracture in the pars interarticularis that is commonly caused by ovaries injury in athletes who perform repetitive back extension and rotation. It typically presents with pain with lumbar extension, which stresses the fracture site, causing low back pain. And causing low back pain, it frequently presents with pain in the lumbar extension, which stresses pain in the lumbar extension, uh, which stresses the fracture site, causing a central low back pain, and occasionally compress the nerve roots, causing radicular pain. In contrast, flexion offloads, and the fracture site is improved, and the fracture site and it improves the pain. Pain typically worsens with activity. Pain typically worsens with activity and improves with rest and night sorry and improves with and night time. Plain extra, plain extra of the lumbar spine is obtained. Plain extra of the lumbar spine is obtained to confirm the diagnosis of this patient, such as this one, whose symptoms have been present 2 to 4 weeks and have not responded to symptomatic treatment. Anteroposterior and lateral views, are usually diagnosis, and the oblique view is not recommended due to additional exposure and limited sensitivity. Patient confirmed spondylolisthesis should limit activity, abstain from continue conservative management, analgesic ICID for 90 days to allow for fracture to heal. After 90 days, who improve can gradually go back to their activities. 90 days. Okay, are you done? Okay. It is age-related dry eye syndrome. This patient, an older woman with dry eyes and a foreign body sensation in the eyes, but no evidence of autoimmune inflammation, negative ANA, normal ESR, as has features typical of age-related dry eye syndrome. Exocrine output from lacrimal and salivary glands declines with age. This is associated with atrophy, fibrosis, and ductal dilatation of the glands. decreased blink rates, oxidative damage, and excessive evaporation of tears due to meibomian dysfunction, and use of anticholinergic medications can also contribute to dryness, eye dryness. Age-related dry eye syndrome is more common in women with increased risk in patients with diabetes and thyroid disorder. Concurrent dry mouth symptoms are also common. Complications include corneal epithelial erosion leading to impaired vision. Management is primarily with artificial tear or other ocular lubricants applied frequently, especially in dry, windy conditions. Cyclosporin drops also be used to increase tear secretion. Dry eye syndrome can be Dry eye syndrome can also be a manifestation of Sjogren's syndrome, which is characterized by lymphocytic autoimmune destruction of the exocrine glands, leading to pronounced xerostomia, dry mouth, keratoconjunctivitis sicca. However, unlike acute age-related dry eye syndrome, patients are typically age less than 65, patient age less than 65, and have evidence of autoimmune disease, scleroderma, rheumatoid arthritis, associated lab markers positive in elevated ESR, elevated anti-Ro and La antibody in patients with age-related dry eye syndrome is more likely than Sjogren's based on the absence of the autoimmune markers and onset at older age more than 65. Okay. In pain, right? Is it Lee-Rich syndrome? Increased pain in the right groin for several months. Radiate. I'm thinking way up. Okay, that is another problem. Patient slowly pro this patient slowly progressive pain relieved with rest as degenerative joint disease of the hip. Osteoarthritis is the most common joint disorder characterized by progressive degeneration of the articular cartilage, predisposition factor, age more than 40, obesity, diabetes, osteoarthritis commonly affects the interphalangeal joints of the hands and large weight-bearing joints of the lower extremity. The pain of hip osteoarthritis is typically felt in the groin, buttock, the pain of hip osteoarthritis, hip OA, felt in the groin, buttock, lateral hip, and can radiate to the lower thigh or knee. Patients may have mild pain and brief stiffness with prolonged rest, but worst pain usually occurs with activity and weight bearing. Examination findings often include decreased rotational range of motion, but synovitis redness is absent. Common X-ray findings include loss of joint space, osteophyte formation, and subchondral sclerosis. Impingement of lumbar nerve root can cause referred pain to the posterior hip, thigh, and lower leg. Hip mobility is normal, but patients may have exacerbation of pain, flexion of the hip with knee extended, SLR maneuver. Okay, is it osteoporosis? Mm, oh, she's on low dose prednisolone. Sorry. Another thing like not osteoporosis, osteonecrosis, like avascular necrosis due to steroid. Okay, this is avascular necrosis, like osteonecrosis due to steroid. Next, okay, yes, this patient with SLE who is taking prednisolone has atraumatic hip pain. This patient who SLE who is taking prednisolone has atraumatic hip pain with normal X-ray findings, most likely due to osteonecrosis, avascular necrosis of the femoral head. Osteonecrosis can develop in disorder that can disrupt the circulation of the bone through microocclusion, abnormal endothelial function, increase intraosseous pressure. It is common complication of the SLE, and the risk is greatly increased in patients treated with glucocorticoid, especially with long-term use. Osteonecrosis of the femoral head is characterized by pain in the groin, thigh, or buttocks that is worsened by activity. Early examination finding may be normal, but progression of the disease can lead to reduced range of motion, particularly internal rotation and abduction and joint instability. In the first few months, X-rays are also often normal. MRI is more sensitive test. MRI can reveal the boundary between the normal and the ischemic bone as well as the zone of hypervascularity. In advanced disease, plain X-rays may show subchondral lucency, crescent shine. Plain X-ray may show subchondral lucency, crescent shine. The deformities of the femoral head. It is sarcoidosis, isn't it? Okay. So this patient presentation within 3 to 4 weeks of dyspnea, fatigue, non-productive cough with bilateral hilar fullness and interstitial infiltrate on chest X-ray is consistent with sarcoidosis. Its diagnosis is made by combination of the compatible clinical manifestation and imaging finding, exclusion of other diagnoses, and non-causating granuloma on biopsy, although neither sensitive nor specific. Hypercalcemia occurs in up to 20% of the patient and can be an additional clue for diagnosis. Hypercalcemia can cause frequent urination, possibly due to calcium deposition leading to tubulointerstitial dysfunction and impaired renal tubule concentrating ability. The mechanism responsible for hypercalcemia is granulomatous activity of 1-alpha hydroxylase, causing increased production of 1,25 dihydroxyvitamin D, increased intestinal calcium absorption. Hypercalciuria is present more often than hypercalcemia and can result in nephrolithiasis. Patients with sarcoidosis who are asymptomatic are often followed without treatment due to high rate of spontaneous remission. However, patients with symptomatic disease, cough, dyspnea, fatigue, hypercalcemia, treated with systemic glucocorticoid. It is more important to rule out granulomatous disease and with similar presentations such as TB, histoplasmosis prior to initiation of glucocorticoid. Okay, okay, we can do it by ourselves. Okay, bye bye. Okay.